So when we think about patient characteristics and selecting treatment, let's talk about the high-risk patients for a minute. So how are you defining those, first of all, because there's some debate in how we're defining those, and then how are you guiding your frontline therapy based on the high-risk patient? Why don't we start with Donna?
Well, it's a moving field, and I think even to back up further, what defines a high-risk patient? I think, and I apologize if you've heard me say this before, but I'm intrigued by the mutational data that shows that we are just scratching the surface with our fish, and that there's only a minority of patients with deletion 17p and 414 translocation, and a subgroup of those with 1114 that are truly high risk. The rest behave like standard risk, but we're lumping them because that's all we've had. And I think when we're looking at this data about high risk, I think the first thing we have to realize is it's really superficial and not that accurate for each patient. And I push for getting the mutational. And there are these panels all over. I mean, we have one at PMH. It's CLIA approved. It costs almost $1,000 a patient. It's not paid for, but it could give us some measurable data. So that's the first point. But I think if we use the classic cytogenetics, most people feel, and I think the data supports that using a PI and an IMiD together, or I would say even PI-based with other drugs, is the best way to go, because we've done our Canadian study of looking at first relapse with RD with 17p deletion, and that group of patients doesn't do very well. They need more. They don't do very well with anything, actually. So I think patients who are high risk, transplant eligible, need a PI and Revlimid, and then your high risk elderly preferably would have RVD.
And probably in line with that, I completely agree, Donna. We were a bit surprised to see, for example, in the castor, when we all think about the PI being superior than an IMiD for the high risk, that the high risk patient, they just improved. They went from 7 months to 17 months, not more than that. And that was surprising because we all thought the immunotherapy will give us that advantage for this specific subgroup of patients. So I think probably, as you said, of course, the definition has to be, of course, well defined. Even all the deletion 17, they are not the same. Maybe you have a deletion, but the other allele still functions. So these are the good deletion 17p patients. But so we have to work on that, I agree, to make this testing be more available for our patients. But second, I think these are the patients where probably more T-cell therapy should be considered at the time of relapse, because again, even data was disappointing in that point of view. Maybe more the CAR-T bites should be considered.
And having said that PIs are important, I think if you look at relapse treatment, which is getting ahead of your question, when you line up all these regimens for 1 to 3 prior treatments, the one that fares almost the worst is KD. 8.8 months in high risk. And I think it's because PIs are good, but that's a doublet. And you don't get as much bang for your buck as if you add almost anything to a PI.